welcome to another lecture, and today we'll be discussing something about the PPHN and its manifestation and its treatment. So PPHN is a very important topic, and we have been seeing patients of PPHN day in, day out. So that is why it becomes a very important topic to understand. Now, PPHN, persistent pulmonary hypertension of the newborn. PPHN is actually the failure of the newborn to transition to extrauterine life. Usually what happens is that PPHN is actually the persistence of intrauterine system of respiration and circulation, which persists after the child is born. And this is detrimental, this is not physiologic, and this is what causes all the abnormality. So you have to understand that it is due to increased pulmonary vascular resistance, which is meant to fall after the patient is born. Patient takes his first breath, patient cries, the child cries. After the first breath, the pulmonary venous resistance will fall. What happens in fetal life is you need to understand fetal to neonatal circulation. Now you have to understand that in fetal circulation, pulmonary vascular resistance is suprasystemic. Okay, suprasystemic. It is more than the systemic resistance. It is suprasystemic. It is not lesser than systemic circulation, because we need the shunting to occur. Now, what does this mean? What happens is that this is the heart. Imagine this is the heart. Okay, this is SVC, this is IVC, pulmonary artery. Pulmonary artery is connected to the aorta by ductus. This is the ductus arteriosus. This is the aorta. Now this is the RA, this is the RV, this is LA, this is LV, and here this is pulmonary vein. Okay. So I hope you understood the diagram. Now, what is important is that firstly, the oxygenated blood comes from IVC. So let's say that the oxygenated blood is red in color. Okay, let's decide the color for them. So oxygenated blood is red in color, and it is coming along with the non-oxygenated blood from IVC, because see, IVC is not purely oxygenated blood, it is also the waste from the lower body, and the deoxygenated blood also comes from the SVC to the right atrium. So there is mixing of blood. Now there is, as you know, there is a Thebetian valve, there is a Eustachian valve, and this valves, what they do is they direct the IVC blood. They direct high amount of IVC blood to shunt to the left atrium. Okay, this Thebetian Eustachian valves, they will help the blood to go into the left atrium, and this left atrium, the blood from left atrium will reach the left ventricle. Okay, and then they will finally reach to aorta. Now, why is this PFO important? Why is this PFO important, patent foramen oval? Why is it important? Because at the end of the day, pulmonary artery is connected to aorta. So why do we need another shunt? So the reason why PFO is existing is that, see, the before the aorta joins the pulmonary artery, the circulation, the common carotid from both the sides has already arisen. So the head, the circulation of the head and the neck and the head is already existed or already given its tributaries before the ductus joins to the aorta. So this is the reason that, see, obviously the blood that is getting shunt from IVC to LA is more oxygenated than the routine blood that is coming from the ductus arteriosus. So this preferential shunting helps in the development of brain, and it is very, very helpful because it provides oxygen-rich blood to the brain via the valves. Okay. So this is the first site of shunting, and the second site is that RA, the blood comes from RA to RV, then it goes into pulmonary artery, and then via the ductus, it goes into aorta. As I told you, that the pressures of ductus, the pressures of pulmonary circulation is suprasystemic. That is why the shunt is from right side to the left side, and this is how the circulation works. So technically what happens is, firstly the LA and LV only receive a very small amount of blood, and pulmonary veins also received extremely small amount of blood, because obviously though some amount of blood will go into pulmonary artery and they will go into the left atria via the pulmonary vein, it is very minimal. That is why this is the fetal circulation, and this is very important. Now how does this why is the PVR more in the fetus? Okay, what is the mediators which will cause the PVR to remain high in the newborn? Okay, so first mediator is the fluid filled lungs. Okay, the lungs are not expanded, the child is not crying in the stomach, and the lungs are filled with fluid. So it is very helpful in increasing the PVR. Second is that there is increased constrictors like prostaglandins, leukotriene pathway. So there are increased vasoconstrictor in the pulmonary circulation. Okay, and also what else is that serotonin mediated pathway. Now how is the serotonin mediated pathway important is that in mothers who were intaking or who had a history of intake of SSRI, the mothers of the children of this mother, the children that were born out of this mothers, they had a very high prevalence of PPHN. So serotonin is also a very important factor which leads to causing of PPHN, and serotonin, SSRI intake in mothers will lead to PPHN in the pediatric population or the newborn. Now, after the birth, at birth, what happens is when you clamp the umbilical cord, the low resistance shunt, the lowest resistance shunt is the umbilical cord, the umbilical vein. So lowest resistance shunt is stopped. Okay, it stops the placental circulation. The low resistance shunt is stopped. So what will this lead to? And after the child cries, what will this lead to is that there is a rapid fall in PVR. There is rapid absorption of the lung fluid. There is rapid absorption of lung fluid, and the pulmonary pressures fall below the systemic levels. On the other hand, the left ventricles become more active. They start pumping the systemic blood, and this will cause the systemic pressures to increase more and the falling of pulmonary pressures. Okay, so this is very important. And later the O2 that is inhaled by the child, this will lead to vasodilation. So the first cry, the child cries in perital asphyxia. If the child does not cry, it may lead to PPHN. So when the child cries, this O2, the local action of O2 will lead to vasodilation, and this will lead into the patient having fall in pulmonary venous resistance. And then there is a reversal of flow from the ductus. Okay, so the flow becomes left to right instead of right to left. So this is what happens at birth. Now, what are the other factors which help in vasodilation? So they are endothelium derived mediators. Now, the most important endothelium derived mediator is nitrous oxide or nitric oxide. It is not nitrous, it is nitric. So nitric oxide is the most important factor which helps into the vasodilation of the patient. So what is this inhaled nitric oxide? So it is endothelium derived nitric oxide. It is endothelium derived nitric oxide, and this nitric oxide activates the guanylate. It activates the guanylate silase. enzyme cyclase, and it will lead to increase in formation. It increases in formation of cyclic GMP. Okay, and this will activate also. This also activates the arachidonic pathway. Activates arachidonic acid pathway, cyclic AMP pathway. So arachidonic acid pathway, which is very important for the prostaglandins. So this is being activated, and the formation of prostacyclins will lead into the vasodilation. So nitric oxide is very important, and this nitric oxide can also be secreted. It is also secreted due to shear stress. The child who starts breathing, there is a shear stress due to the increased breathing of the patient. So this breathing will lead into the presence of or the development of decreased pulmonary venous resistance. Okay, so this is the very important thing. Now next is etiology. So etiology is very, very important. PPHN occurs due to two reasons. One is the primary and second is the secondary. So primary is idiopathic PPHN. Secondary are the causes like congenital diaphragmatic hernia or abnormal vasculature or RDS or any cyanotic heart disease, congenital heart disease. And the classification that you need to understand for the PPHN is the Panama classification, where it has been divided into the 10 types. The PPHN is differentiated in 10 types according to the etiology. So this is the important Panama classification that you need to just name is important. Obviously, no one can remember the classification on their own. Now, there is another manifestation which is known as malignant TTN. Now, what is TTN? Transient tachypnea of newborn is due to persistence of the lung fluid after a cesarean section in a full-term male child. What happens in malignant TTN is there is a severe morbidity. Now again here the lung fluid fails to get absorbed, but this lung fluid will lead to PPHN. This lung fluid will lead to PPHN and it will cause severe morbidity and mortality. And this is actually the combination of TTN with PPHN. So this is how you need to understand in the child. So this was one thing that I wanted to gain your attention to. Sometimes if you might see that malignant TTN, you will be worried that, oh, I've never heard about it. So this was just focusing your attention to. So now let's draw a diagram. This is a smooth muscle cell. Okay, this is a smooth muscle cell, and in the smooth muscle cell, calcium. This calcium that is there in the smooth muscle, this will cause vasodilation. So anything which will increase the promotion of calcium, which will stimulate the calcium, it will cause vasodilation. So again, as we talked before, there are two things that can stimulate the calcium. One is cyclic AMP pathway and second is cyclic GMP pathway. So this is very, very important, the cyclic GMP and cyclic AMP pathway. Now the cyclic GMP is formed by soluble guanylate cyclase enzyme that we talked about, which is stimulated by nitric oxide. Okay, it is stimulated by nitric oxide. So this is how nitric oxide works, and it is secreted from the endothelium. It does not exist in the smooth muscle. It is secreted from the endothelium. While the cyclic AMP is formed from the arachidonic acid pathway, and it is stimulated by PGI2. Okay, prostaglandin I2, and it is the enzyme that is there over here is the cyclooxygenase enzyme, COX enzyme, cyclooxygenase enzyme. So this is very, very important. That first thing you need to see is that I will show you the activity of all the drugs. So this is the first drug, nitric oxide. How does nitric oxide act when you give it in PPHN? This is the first thing that you need to understand. Okay. Also, there is an enzyme which will cause the conversion of cyclic GMP to simple GMP, and that enzyme is known as PDE5. Now, when this PDE5 is inhibited, there is decreased formation of GMP from cyclic GMP, and here we have everyone's favorite drug, sildenafil. Okay, everyone's favorite. This drug was actually, the little history is that this drug was made by Pfizer for PPHN, but one side effect, it was so good that they abandoned. Actually, it is still being used for PPHN, but majority of its sales do not come from the PPHN. They come from something else, which you know. Okay. Now there is another enzyme which will convert cyclic AMP to AMP, and that enzyme is PDE3. And this PDE3 inhibition is done by another drug known as milrinone. Okay, milrinone, very important. Milrinone is an inodilator, PDE3 inhibitor, and it will inhibit the formation. Okay, and then there are other two drugs that I need you to remember are, first is there is PGE2 stimulator, which is known as alprostadil. Alprostadil, which is PDE, prostaglandin E, PGE, which is a PGE analog. Okay, so it will also act at the site where PGI2 acts, while prostacyclins themselves are PGI2 stimulants. So these are the two drugs which act on this site that I have shown you. So the reason why I started from calcium is that it was going to get messy, and it is very difficult to understand it later once it has formed. Okay, and the last drug that we need to understand over here is the endothelial receptor antagonist. Okay, antagonist, and that is bosentan, ambrisentan, valsentan. Okay, so these are endothelial receptor antagonist, and these are the last drug that you need to understand in PPHN. So I hope you understood this entire thing before we go ahead, because if you did not understand this, drugs also you will not understand, and rest all also you will not understand. So this is very, very important. Now we will see different scenarios. First is PPHN in preterm. PPHN in preterm is mostly exclusive to RDS. Exclusively due to RDS. Due to RDS. Okay, it is exclusively due to RDS, and this is the most common etiology in a preterm. Also, later this RDS and too much, the RDS causes the damage to the lungs, and later on, they require O2, they lead into BPD. And this BPD, bronchopulmonary dysplasia, will also lead to long-term PPHN in the patient. So this is very, very important, that in PPHN in preterm is most commonly due to RDS. Second is PPHN with CDH, congenital diaphragmatic hernia. A mega lecture of congenital diaphragmatic hernia is in pipeline, and it will be here in 1 week or 2 weeks. So you have to understand that in PPHN, in CDH, PPHN occurs due to lung malformation. Lung malformation. Also, there is malformation of the arteries and the vasculature of the lungs due to CDH, and this is why this all happens. There is lung hypoplasia. And the PPHN in CDH is actually the very resistant one, and it causes more. It is difficult to treat compared to the other ones. And the last one is the alveolar capillary dysplasia, and this is the malformation that I was talking about. Again, here what happens is there is misalignment. What happens is with one alveoli you always have an artery and vein, but there is a misalignment due to this. So there is ventilation perfusion mismatch. Okay, and this will lead to all the abnormalities that we have talked before. So these are the few specific etiology that I need you to draw your attention to. Okay, so next is, what are the clinical features? Okay, what are the clinical features of PPHN? So very, very important. that differentiating CHD from a PPHN is very, very important. And there are multiple tests. But I will tell you a very, very easy to understand thing. Now, this is the arch of aorta. This diagram I have drawn around hundreds of times, and 3-4 lectures also I have focused on this. But for those who did not see that lecture, this is for you. If you have already seen this diagram, then skip it because it will be a waste of your time. So this is very, very important. Okay. So this is the arch of aorta, and on the left side of your screen, you will see that this is a brachiocephalic trunk. Brachiocephalic trunk on the right side will lead to the subclavian and common carotid. And on the left side, common carotid and subclavian have different origins. So these are the branches of aorta. Now the most common site of ductus is over here. Okay, the most common site of ductus is where I have shown you. The second most common is over here. Okay, so first most common site is where I have written 1, and second most common site is where I have written 2. Now, why is this important is that when you have PPHN, the lung pressures are suprasystemic. Okay, so when the ductus is attached over here on the site 1, let's use a red color marker for that. Okay, so this is the site of attachment of ductus, and the 2 we will show it with a blue marker. Okay, so imagine that there is shunting of blood. What is the difference between 1 and 2? In 1, it means that the ductus blood enters circulation, or the deoxygenated blood that is coming from the right side to the left side enters the circulation after the origin of carotids. So the CNS is not involved. The CNS is not involved, but this left subclavian becomes the area which is after this shunting has occurred. Plus, some amount of deoxygenated blood will go into left subclavian. Some amount will go into the systemic circulation. While in type 2, what happens is there is no blood that is going into the left subclavian. So see, simple thing is that the circulation that occurs which exists before ductus attachment, it is known as preductal. Now, in the example number 1, preductal is the right upper limb, the right upper limb ka circulation is over here. So it is before the attachment of the ductus, plus left upper limb is not a part of preductal, it is part of postductal, because as you can see in the image, you can see that the ductus is attached before the subclavian arises. So postductal is left upper limb and both lower limb, because this red color line goes down also. Okay. While in type 2, right plus left upper limb is preductal, because the blue color marker occurs, or it joins the systemic circulation after the subclavian has arisen. So right and left side upper limb is preductal, while the lower limb stands to be postductal. Now, unless you do 2D echo, you do not know which type of circulation a patient has. Okay, you do not know the type of circulation a patient has. That is why we always assume the right upper limb as preductal and any of the lower limb as postductal. We do not use left upper limb as preductal or postductal unless we know the site of attachment of ductus. So this is first and foremost very important thing. Now next is that as the suprasystemic pressures are more, there is a phenomenon known as differential cyanosis. What is differential cyanosis? There is a difference. There is a difference of SpO2 of 5 to 10% between upper limb and lower limb, obviously, because the upper limb has the normal blood which is not mixed, while lower limb has a deoxygenated mixed blood. So there is cyanosis in the lower limb, but there is no cyanosis in the upper limb. So it is known as differential cyanosis, and differential cyanosis occurs when SpO2 difference is around 5 to 10% and PaO2 difference is around 10 to 20 millimeter of mercury between upper limb and lower limb. So this is what differential cyanosis is. It also occurs in coarctation of aorta. My video, my lecture on coarctation of aorta, I have already taken. And for cyanosis, there is a separate lecture on YouTube. It is a very short 5-10 minute video. Please go and look at it, and you will understand that why differential cyanosis occurs if you did not understand it from here. Okay. The reverse differential cyanosis may occur. Reverse differential cyanosis may occur when you have TGA with PPHN. Obviously, the circulation is inverted. It occurs in TGA with PPHN. So this is differential cyanosis, and which is very, very commonly seen with PPHN compared to cyanotic heart disease. Okay, so this is very, very important. Also, there is a labile hypoxemia. Labile hypoxemia and fluctuating SpO2. Fluctuating SpO2, because see, the pressures of the lung depend. See, pressures of the lungs are very sensitive to sound noise. So imagine if you have taken the the ABGA after a huge sound, there will be increased shunting. So it is very labile, the SpO2 and hypoxemia, and they are very responsive to sound and lights. So it is very important to keep them both covered when you manage PPHN. Okay. Now, you also have to understand that the test that we do is hyperoxy test. Hyperoxy test is after giving 100% of O2 and less than 100, it is more likely to be a cyanotic CHD, and more than 200, it is more likely to be respiratory cause. So hyperoxy test is very, very important to differentiate between the other causes of cyanosis. Echo is the treatment of choice, gold standard. It is the investigation of choice and the gold standard. And that is very, very important. It will also help us to see multiple things. Now, what are the findings of echo that are suggestive of PPHN? Okay, so let's draw another diagram. Okay. Okay, this is the normal heart. Okay, this is right atrium, left atrium, right ventricle, left ventricle, and then there is this PDA, everyone's favorite. Okay, PDA. Okay, now this is the normal heart. Okay, there is a foramen ovale over here in the atrium. Now, everything that I show you in red color is suggestive of PPHN. So first thing, what is important in PPHN? So there is, first of all, tricuspid regurgitation. Tricuspid regurgitation. This is the first finding, because the pressures on the right side are more, the PVR is more. That is why some amount of regurgitation will occur in the patient. So first thing is tricuspid regurgitation. We see that in continuous wave Doppler. There are multiple pulse wave Doppler or continuous wave Doppler, but for regurgitation, we need to see that. You remember that red and blue color, that is very important, against and opposite to the direction of the probe. So you can obviously see, routinely this reverse direction is not seen. If it is seen, then you might suspect that there is a TR. There is a deep displacement of the flank or the valve. Okay. So first thing is this. The second thing that you need to see is the septum. The septum is deviated towards left side. So second is septal deviation, because right side pressures are more. So septum will deviate towards the left side. Septal deviation is there. Okay. Then again, third one is there is right to left PDA shunt. Okay, because right side pressures are more. So ductal shunting will occur from right side to left side. This is very, very important. Fourth one is abnormality. Fourth one is right ventricular dysfunction, because again the pressures on the left side is very high. So right ventricular dysfunction is very, very common, and it is seen. Okay. And the fifth one is the PFO shunt. PFO shunt. Fifth one is PFO shunt. So this is what are routinely seen in the patients of PPHN. These are the findings that you commonly see in the PPHN, and the displacement of the tricuspid valve is a very important determinant for severity of PPHN. Okay, so this is very, very important. Now, after you have done echo, you have to manage the patient. So how will you manage the patient? So first we'll understand the general treatment of management. Second, we'll see the specific management of the treatment. Okay. So first is the general management. So what you will have to do in the general management is, first is minimal stimulation. Cover the eyes and the ears, and do not let them expose the loud sounds, which will increase the pressure. Then next is sedation and analgesia. Ventilation is very important in PPHN, and if the child continues to fight the ventilator, the child will not be oxygenated. That is why it is very, very important that you see the analgesia and sedation. And next is 8 to 9 rib dial. The rib expansion is more than enough. And what are the ideal convention parameters for PPHN? So what are the recommended parameters? So FiO2 is obviously variable for each and every patient, but for ideally the PEEP should be less than 25 millimeter of mercury. More than 25 millimeter of mercury, prefer giving HFOV. Okay, PEEP PEEP is 5. This is not millimeter of mercury, it is centimeter of water. I'm really sorry. Centimeter of water, 5 centimeter of water, and rate is 40 per minute. So this is the ideal parameters of the convention ventilator when you keep. If you go for HFOV, I will be putting a separate lecture of HFOV. HFOV is a very long topic, and depending upon, either you keep it HFO mode or you keep it under the high frequency jet ventilation. Jet ventilation is nowadays not used very commonly. HFO is more commonly used. So in that we have pore pressures. Pore pressures are actually the mean arterial pressure, MAP pressures, that are very important in HFO. So that is the thing that you need to understand. Also avoid hypotension. Okay, so these are the general treatment that you need to understand for PPHN. Okay, now next management is mechanical ventilation. Now, as I told you, that the target that you are achieving is that the PaCO2 or PCO2 should be less than 60 millimeter of mercury. This is very, very important, and this is the target, and the tidal volume should be achieved at 6 ml per kg. This is probably more than enough for achieving the desired result in patients of mild to moderate PPHN. And as you know, that O2, as I told you before, O2 is a dilator. O2 is a vasodilator, but the issue is that if you give high FiO2 to the patient, ductus will also stay open. So that is why it is a double-edged sword. Very high amounts of oxygen also causes pulmonary vasoconstriction to some degree, but in low doses, O2 is a pulmonary vasodilator and not a vasoconstrictor. So this is very, very important. And the ventilation for PPHN is the gentle ventilation. The word that is used is gentle ventilation, not too much pressure, not too much FiO2, and not too much stimulation. So that is the gentle ventilation. What are the markers of adequate ventilation is PaO2 between 55 to 80, PaCO2 less than 60, urine output more than 1 ml per kg per hour. Okay. And last one is serum lactate. Okay, lactate should be normal. And the post-ductal SpO2 more than 80. Okay, 70 to 80 is also acceptable. And in a patient of CDH, initially 85 is 70 to 80 is normal when it is associated with CDH, but later on they may go as up to 90, but then more than 90 is detrimental. So do not cross the limit of SpO2 of 90. 100 SpO2, many of people keep it 100 so that it is safe. It is not safe, it causes more damage. Okay. The next is surfactant. If you have a RDS associated PPHN, surfactant is very important. The poractant, which is Curocurf. or you can give also the Sarventa, whatever Neo Sarventa, whatever is available at your place. So this is very, very important. Next is the pulmonary vasodilator therapy. Now this is a very important part, pulmonary vasodilator. So first and the most important and the most efficacious pulmonary vasodilator is INO, and it is the only FDA approved therapy for PPHN. Rest all are not approved. So INO is the only approved therapy for PPHN, and it is a selective pulmodilator. Okay, so this dilator causes it decreases the pulmonary vascular resistance, but it does not affect systemic vascular pressures. Okay, it does not affect systemic vascular resistance. So this is very important. It is a very selective drug, and which this leads to, what is the mechanism of action is, as we told you, but what are the manifestations? There is increase in ventilation perfusion ratio. Okay. Also, when the INO is inhaled, it preferably goes to the place where there is highest ventilation, or the O2 reaches to the highest amount. The nitric oxide gets absorbed in those alveoli where the O2 perfusion is highest. So its effect is also highest where the O2 is their highest. So this is very, very important, that it improves the oxygenation. Also, there is increase in ventilation and increase in perfusion separately. Okay. Now, next is that INO is the only therapy that I told you is approved in full-term patients. And what are the, when do you give nitrous oxide? So initiation of nitric oxide is on rule of 20. Okay, what is rule of 20? Rule of 20 is that start nitrous oxide when oxygenation index is less than 20 at dose of 20 parts per million, and the target PaO to FiO2 ratio. The target PaO to FiO2 ratio. The target PaO to FiO2 ratio should be more than 20 millimeter of mercury. Okay, 20 millimeter of mercury. Here, see, map is not there. Okay, this is not oxygenation index. It is PaO to FiO2 thing. Okay, so please understand, this is not oxygen index. If there was presence of MAP, then it would be a marker of PF ratio, and which is used for ARDS. This is not PF ratio. This is PaO to FiO2 ratio. There is no mention of MAP over here. So this is the targets. Very, very important. The initiation, the nitrous oxide is used according to the rule of 20. Now, what are the monitoring parameters? So first, very important, a side effect of nitrous oxide is methemoglobinemia. What happens is this nitrogen that goes into the bloodstream, this will cause the nitrogenation. The nitrogen will increase in the bloodstream, and it will lead to methemoglobinemia. So the measurement of methemoglobin levels are done at 2 hours, 8 hours, and then 24 hours, followed by 24-hourly measurement. Okay, followed by 24-hourly measurement. And the oxygenation response. Okay, this is very, very important, that this methemoglobinemia, many centers measure it only for unless the dose is maximized or the dose is increasing. They do it for first 48 to 72 hours, then they assume that it will not increase because it has not increased unless you increase the dose. Now, when to wean off nitric oxide, very important, and this is rule of 60. Okay, rule of 60, very, very important. Wean off when FiO2 is less than 60%. Okay, and PaO2 is more than 60% at that FiO2. So this is very, very important, and this should be present for at least 60 minutes. This when you lessen the FiO2 less than 60, the PaO2 should be more than 60 millimeter of mercury for at least 1 hour or 60 minutes. So this is the rule of 60, 60, 60, 60, and this is very, very important. add this PaO2 more than 60 is actually the SpO2 more than 90%, more than or equal to 90 in the post-ductal circulation. So when the SpO2 is being maintained for more than 90, below the FiO2 of 60% for at least 60 minutes, then you can obviously, when you do not have PaO2, you can take a surrogate SpO2 for PO2. Okay, so this is very, very important. Now, how to wean? How to wean? Now, as I told you, the dose is 20 parts per million. Initially, you have to decrease by 5 parts per million dose of nitric oxide every 4 hourly. And then once the dose has reached to 5 ppm, imagine that the dose was 20 ppm. After 3 improved responses and after 12 hours, you decrease 5 ppm. The final dose is 5 ppm. Then the 5 ppm dose you have to decrease 1 ppm every 4 hourly until the dose is 0. So this is very, very important. This is how you wean the patient. Okay, and this is how nitric oxide is given. Now the main things come, that when nitric oxide is unavailable. So what will you do when nitric oxide is unavailable? Give me a minute. So when nitric oxide is unavailable, you have 4 present scenarios. So first scenario is that the BP is normal. There is normal BP with good cardiac function. So when the BP is normal with good cardiac function, the drug of choice, when nitric oxide is unavailable, the drug of choice becomes sildenafil. Sildenafil, as I told you, sildenafil can be used IV and oral both. And sildenafil is a PDE5 antagonist. Okay, as I showed you in that image, where does it act? It acts on the cyclic GMP pathway. It stops the conversion from cyclic GMP to GMP. Okay, so PDE5 here, as I will show you, cyclic GMP is converted by PDE5 into GMP, and this degeneration or the degradation of cyclic GMP is decreased by sildenafil. Okay, so sildenafil, very, very important. Then sildenafil is given in the loading dose and the maintenance dose. Loading dose, maintenance dose, very, very important. What is the loading dose? It is 0.4 mg per kg over 3 hours. And the maintenance dose is 1.6 mg per kg 24 hourly. Okay, per day. That is the maintenance dose. This is the IV dose. Oral dose 3 mg per kg. 3 mg per kg. This is the dose that you give. This is the dose for sildenafil oral. Now this loading dose is very easy to calculate. Imagine the child is actually this is a cheat code, not be valid for everything. So weight divided by 2. Okay, weight divided by 2 is the 4.4 mg per kg, and 2 into weight is actually 1.6 mg per kg. So what does this mean is that the child, imagine, is of 2 kg. The child is of 2 kg, then the dose of sildenafil is 0.2 ml that you will dilute in the total that you will dilute in the patient. This is 0.8 ml, 0.8 ml the mg per kg. So 0.4 mg per kg. So the weight is, imagine, I'll show you with an example. So loading dose is weight ka half. Okay, so imagine that the patient into 10, obviously into 10. So you have to take this weight by 2. So imagine it is 2 kg divided by 2. So you take 1 ml. You take 1 ml sildenafil and mix it with 29 ml NS. Mix it with 29 ml NS, and the total solution is of 30 ml. The rate is 10 ml per hour. So the 30 ml will be given in 3 hours. And for the same patient, the maintenance dose, you have to do it 2 into weight. So it is 4 ml sildenafil. It is 4 ml sildenafil plus 20 ml NS, 20 ml NS, and the rate is 1 ml per hour. You have to make a pint of 24 ml. In the initial thing, you have to make a pint of 30 ml because you have to give it for 3 hours. So this is how you give sildenafil. If you did not understand this, please go according to the mg per kg dosing. But this is very, very important. If this does not work, then you have to give ECMO to the patient. So this is very important. Next are aerosolized. If the nitric oxide is not there, then if you have aerosolized PGE1, L-prostative. If you have aerosolized PGE1, you have to give it at the dose of 150 to 300 nanogram per kg per minute, diluted in saline, diluted in 4 ml per hour saline. That you have to give. And the dose of inhaled aerosolized PGI2 is 50 nanogram per kg per minute. Okay, so these are the dose of PG1, PGI2. I have not visited anyone or any center that is using this, but for theoretical purposes, please remember. The second is when there is normal BP, but LV dysfunction is there. LV dysfunction is there. The drug of choice becomes milrinone. Milrinone is PDE3 inhibitor. Milrinone is an inodilator. And this milrinone actually in this condition, when you have normal BP with LV dysfunction, inhaled nitric oxide is contraindicated because it increases the chance of pulmonary edema. Because there is obviously left ventricular failure, there is increased chance of pulmonary edema. So that is why the usage of inhaled nitric oxide is inhibited when there is LV dysfunction. And the loading dose of milrinone is 50 microgram per kg over 30 minutes, followed by maintenance dose of 1 microgram per kg per minute. This is also 1 microgram per kg per minute. And this is the dose, maintenance dose that you have to give for the milrinone. So this is very, very important. Again, if there is systemic hypotension, do not give loading dose of milrinone because it is a dilator. So it is not only inotropic agent, it is inodilator. That is why if there is systemic hypotension, avoid giving loading dose of either sildenafil or this milrinone, or else the patient will die. But when you have, in the third situation, when there is low BP plus good cardiac function, okay, then low BP with good cardiac function, the drug of choice is IV fluids. IV fluid, give 10 ml per kg bolus twice if possible. And if this does not work, then you start dopamine. Okay, if dopamine does not work, give noradrenaline or vasopressin. Also, you can give inhaled nitric oxide, you can give O2 to the patient. So this is when there is low BP and good cardiac function. Now, fourth is low BP with bad cardiac function or LV dysfunction. LV dysfunction is there. Now, in this condition, the ideal treatment of choice is ECMO. But again, ECMO is not available. Extracorporeal membrane oxygenation, the ECMO that was used in COVID. What they do is in ECMO is that they do the oxygenation outside the body. Like in the hemodialysis, they run the blood outside the body, and there they oxygenate that blood outside the body, and then they put the blood back again. So the ECMO membrane or the ECMO machine works as the heart and the lung of the patient. Okay, it is actually a type of cardiopulmonary bypass. Here, ECMO does primary working of lungs and heart. But again, ECMO is not available everywhere, so you have to give milrinone. The second choice is milrinone without loading dose. And you can also give dopa, norad, adrenaline, dobute, all the cardiopressors you can give. This is not a very ideal situation. Obviously, the patient has a very less chances of survival. So this is actually what you have to do. So we will summarize it for understanding. So when you have a suspected PPHN, do echo, and you do lung recruitment with surfactant and momentary increase in adequate PEEP. Okay, then you have 4 situations. First is normal BP, normal LV function. Second is normal BP, abnormal LV function. Third one is abnormal BP, normal LV function. And last one is abnormal BP and abnormal LVF. In the first condition, give O2, give O2, give INO, give sildenafil, and give inhaled PGE2 or inhaled PGE1. Oh, sorry, I2. Okay. Okay. The next one is normal BP with abnormal function, IV milrinone. In abnormal BP, normal LV functions, you give IV bolus, fluid bolus, followed by dopa, NORAD, or vasopressin. And in the abnormal BP, first give ECMO, abnormal BP, abnormal function, rapid deterioration, give ECMO. And if it is not there, then you give dopa, NORAD, adrenaline, dobute, vaso. You can also give hydrocort. Okay, so all this can be given, and this is all in all the summary of the treatment of PPHN, and this is how you manage the patient of PPHN. Okay, that's all for today, guys. I hope you like the video and you learned something new from this, and I'll see you in the next one.